July is always a great time of year to sort of launch a new initiative, and today I'm really thrilled to have as our visiting speaker Dr. Tracey Dechert, who is a trauma surgeon at Boston University, did her trauma training at the same place as our own Skeeter Salcedo at Penn, and she has been instrumental in launching a new initiative at Boston University that we are, I think we're going to be hope to be the second or the first satellite chapter. It's now a national organization with a secondary chapter. And she's going to tell us a lot about this effort that has been spearheaded, I would say, from the ground up by our residents here who in particular have come from BU and got exposed to this as medical students. I'm really looking forward to your comments and so happy to have you visit us. So thank you.
Thank you so much for the opportunity to come here and present our work. We are thrilled beyond belief to, one, be involved in the work that we are involved in back at home, but also then come here and hopefully engage with you guys and collaborate and work together from here on. So I'd like to also introduce Megan Janeway, who is one of our surgery residents who has been instrumental in this group. She stayed on as she was a medical student and then stayed on, luckily for me, in our residency. So now she's stuck with me for a decade or so. So maybe a reason to consider moving for residency if you're a med student. The only disclosures I have is I'm a big fan of French Impressionism, and I put it throughout the talk because some of these topics can be somewhat sad and depressing, so then the artwork will lift us up as we go. And she already mentioned, Dr. Farmer already mentioned my other disclosure, which is I worked with Skeeter. He came after I was already there. I had nothing to do with that, so you can't hold that against me. And of course I'm teasing. He knows I'm here picking on him. So these are the objectives of what I'm hoping to accomplish with this talk today. And we can skim through some of these. We won't have to take too long, but these are our goals. And I wanted to start with the fact that we are surgeons, and yet still so many other specialties wonder what we're doing in this arena and why we're talking about it. Or if they hear us talking about it, they are so thrilled and surprised. And that's unfortunate, because we don't want surgeons to be thought of as people not in this area. And especially as our medical students are coming up, we don't want them to not choose surgery because they have passion and interest in public health, for example. So why do we need to discuss? Because it is data over and over of course, underserved populations have higher rates of trauma, they present with cancers at later stage, and they just, in general, receive worse surgical care. And then that, unfortunately, when you look at it globally, also even a bigger issue in the sense of the majority of the world's population does not have access to surgical care, which includes anesthesia, OB-GYN, kind of the whole picture. And then when you look at that the poorest third of humanity receives 3.5% of the world's operation. That is just heartbreaking. So we need to discuss this as surgeons. We need to be in this area, and we need to fight, obviously, for why we're here. And also, there is us as providers. It's unfortunate, but it's true. And of course, we have to recognize that we have biases ourselves. So as surgeons or as any type of doctor, to think that you do have unconscious bias, that you are having to think about cultural competency, language usage, and so forth. And I know here that this all should ring true to you guys, just like it does to us back in Boston. But you take all this, and this is why we need to have us in this area fighting and doing this work. Because if we don't address these underlying causes, then we're just going to keep perpetuating this inequity. See, it's already depressing. So you need some artwork to cheer up. So what's also thrilling is SDH, which many of us grew up thinking was subdural hematoma. Now the medical students all know it's social determinants of health. So we've come so far in just my career, but as always, recognizing that, and historically, it humbles us to know that people figured things out a lot longer than we often think they do. So it was in the mid-1800s that people already recognized, hey, if you are poor, that's unfortunate because you're going to have worse health. And we are now still, of course, combating this. So these are definitions of the World Health Organization. People are just discussing this so much more, and I don't know how it works in your medical school here, but our medical school classes now actually do get training on this more formally, which is lovely. So then when they come to us already as interns, they are familiar with these topics. But I do think we have some catching up to do, because there's many of us in our training did not get this. So hopefully we'll all be on the same page in time. And this was put together showing like it really is a lifelong learning type of thing, as in any other part of medicine. We don't just learn it in med school and then we're good. We have to continue. And in this case, we have to engage not just the hospital and medical center, but the community as well. So these topics fit with educating ourselves, being the whole organization, but also the community at large. So the goal, of course, is to have better strategies to improve health. So again, when we think about these topics, as far as social determinants, it's often pediatricians and family medicine that really do this really well. So one, we should work with them and collaborate with them as well and take lessons from them, because they have been doing this. But it does fit in surgery too. So I'm trying to highlight some of the ways that we as surgeons have to be thinking about this. So under education, I have listed there the obvious issues with education, but when you look at economics, so for example, if your insurance status, of course that affects if you have surgery. If you're uninsured, you're not going to have surgery because you have no PCP to refer you for an elective type surgery. If you live in a neighborhood with a lower socioeconomic status, that has been proven to be the single most important predictor of injury in children. So it's the neighborhood that you live in and the SES of that neighborhood. And then geography, many examples of how this affects us as surgeons and our surgical patients. That if you are rural versus urban, there's disadvantages to both, unfortunately. So you can be subjected to poor access to surgical care, even if you're urban, but also if you're rural. So this is Matisse, if anyone wants to learn a little bit about art as well as surgery. Okay. So looking here in our country, we are, of course, thrilled and proud to work here in our country, knowing we do really great care. But even here, we still have work to do. And that's, I think, another point which I was going to get to later when I talk about SRS, is that so many students still think you have to travel to take care of underserved patients. And I'm not saying we shouldn't travel, which I'm going to come to, but you have to realize that we have issues right here. We have underserved patients in our country, and this slide is trying to show you that. So when you look at the counties that are the richest in our country and the counties that are the poorest, the difference in surgeons and the difference in the poverty rate, of course, going along with how many surgeons, striking. So the sort of good news, I guess, in a sense of this slide is that as medical students, as you're making decisions, if you want to be a surgeon, that's great, because we still need more surgeons. So primary care is an excellent field, but we also need surgeons too. So don't be afraid to jump in. And here as well, 1/3 of US counties have no practicing surgeons. So tend to, of course, be rural counties, but still. So when you look at that area of land in this country, that's 9.5 million people who don't really have access to surgeons, which is quite a bit. So examples of whether you live rural or urban, you still can be suffering from the fact that you're underserved. So there's a term called urban disadvantage, which is the fact that myself as a trauma surgeon, which it sounds like you have similar cases here, that the fact that I'm operating on colon cancer should of course never happen, but yet it does. And that is patients who are right within Boston. So they are urban disadvantage. If you are a trauma patient, if you are uninsured, you're more likely to die from your injuries. So although we take everyone in trauma, we never stop anyone at the door, but somehow those underserved patients still are at increased risk. And then if you're rural, like you were presenting earlier this morning with your case, maybe some of the more rural parts, if you have a AAA, you have a greater risk of rupture. You are less likely to have a treatment for bariatric surgery or evaluation. And then, again, higher mortality rates. So it can be depressing because where can you live? It seems like wherever you live, you can be a victim, unfortunately, of circumstances. And this is just showing you the trauma situation. I guess you would probably realize that the purple is the trauma centers. The white is not. And the purple right up there, that is my former resident, I'd have to say, Alicia. She's in Alaska, so she's the trauma surgeon up in Alaska right now. So looking at trauma care, we all know that having access to a trauma center improves your morbidity and mortality. The outcomes are better if you can get to a trauma center quicker. So when you look at the white and see those vast areas, that's 45 million people who don't have access to a level 1 or level 2 trauma center within an hour. So again, very significant. Now we get some water because it's getting more depressing. So this should be hopefully cheering you up, but at the same time, we're staying on point. So now we leave our country and say, let's think a little bit more globally. What's happening there? So 1/3 or so of global burden of disease is actually surgically treated conditions. So too many times when we think about global health, again, we're thinking about infectious disease and things of that sort, which again, fine, we should, but we also have to realize a huge percentage of health is related to surgical diseases around the globe. So we have to be thinking about how do you get access to not only affordable, safe surgical care, but also affordable, which is an issue. And then, of course, that includes, like I said, anesthesia and OB-GYN and maternal health. So similar to the map of the US and trauma centers, this you can guess which colors are the colors where there are not as enough access in surgical care. So when you look at high-income countries compared to low and middle-income countries, the number of operating rooms is quite significant difference. And then in Africa, 1 African surgeon for every 100 American surgeons. And sadly, often in the countries that are lower middle income, the surgeons who are there go to the city. So then there's a whole, again, rural area of these different countries where there's no surgeons. So this is giving you a sense of what proportion of our globe does not have access to safe, affordable surgical care. So there are people, of course, who are now working on this. And this is from the Lancet Commission, and they're really trying to push the idea that historically people thought surgical care could not be done globally because it was too expensive. And so this group of commissioners and people from basically all around the world, all different countries, got together to sort of write this landmark paper, a white paper to sort of show here's what we have to be thinking about. And they came up with 5 key messages. And this is a summary of their paper, showing one, that look at how many people still do not have access to us as surgeons and the work we do, and 5 billion is quite a high number. And then you also look at how many surgical procedures would you need to save lives and prevent disability. And then unfortunately there are people who get surgical care in some of these countries, but then they have catastrophic expenditures for those surgeries and then are in, unfortunately, a terrible position even after their surgery. So realize that we can invest in surgical care and we can do it and it can work and we can save lives, it can be affordable, and we can promote economic growth. But to do all this, of course, we have to make it part of healthcare, but we have to engage local governments and so forth. It's not as if we can just go and do things like this in other places. We have to work together to make surgery part of healthcare. Are the paintings working? Yeah, okay, because you all seem so glum. Is it my topic? I'm sorry. It'll end on a high note. How's that? It'll end on a high note. So, we're surgeons, we're physicians. Why does all this matter to us? Well, here's why. I think that we as physicians can advocate for social change. And when you look at some different organizations around this, in this country, or in this case in Canada, that there are different organizations who comment on social responsibility for physicians and things that we should do. And there's even an organization several decades ago, after you were born, Doctor, I'm sorry, I forget your name. Abby. After you were born, before you were born, there was PSR, which is Physicians for Social Responsibility, which you don't remember because it was before you were born, but they were fighting nuclear weapons. So the idea of social responsibility in medicine goes way back, but we have to continue. If you can imagine, there's a lot still to do. unless it's different here than in Boston, but I have a feeling it's not, unfortunately. So we need to be advocating for all of this for our patients, and then in a sense in the bigger community and so forth. So Dobson, she has done work in this area and published in Academic Medicine, and sort of trying to get the idea of what's the difference between activism and agency. And it's a great concept because every day we're working on behalf of our patients. Like discussed in M&M, you're talking about how there's patients in a nursing home and the care, and there's a delay in care because of that. So we're constantly, where do we discharge this patient to? Is it safe? We do that every day. So we're working for our patients. But then you have to think we should possibly be working bigger than that. And that would be activism, where you're trying to change the actual conditions so your patients don't have these problems that you're dealing with. Like, wouldn't that be great to, instead of being worried about their nutrition and if they're going to heal their wound, to actually not have to have them worry about nutrition before they even come to you? So that's kind of the idea of trying to say we as physicians are doing both, or should do both. So you're trying to work the system, which is usually a negative connotation, right? But we're also trying to engage so that we can change the system. And that's why it's so great when we give talks and there's a lot of young, energetic people in the room, because it's all on you, no pressure. But the young people, like us old ones, it's too late. So it's gonna all come from you guys who are in medical school and starting residency. So several years ago, at BU, there's a very active med student group. They're great, just like I'm sure here, where they're very energetic and enthusiastic and want to save the world and do great things. But I got tired, I have to say, of people thinking, one, they had to travel the world to do that. Like, I have to go to Haiti, I can't just stay here. Not to discourage people from going to Haiti, but, And then the other thing I got tired of was that so many students were like, oh, I love this type of thing, but I guess I can't be a surgeon. And that, of course, is heartbreaking to those of us who are surgeons because, one, we need more surgeons, as you just saw, but also we don't want people thinking that surgeons are cold and heartless and we don't care about social issues. I'm sure there are some surgeons who don't, but there's also other types of doctors who don't. Like, it shouldn't just be labeled with our specialty. So back in 2014, we came up with this idea of socially responsible surgery. And it fit perfectly because at our hospital, we are a safety net hospital of New England. We get patients all over the region who are poor and underserved and underinsured and so forth. So as you can see, 3/4 of our patients are underserved, which is a lot. And then about 1/3 of our patients, English is not their first language. So the work we're trying to do fits really well at a place like Boston Medical Center. So we founded this group with the idea that we're going to pull in social responsibility as surgical practice. And then we came up with these 4 pillars in a sense of what will this mean and how are we going to frame this to do work in this area. So we thought these are the 4 areas we really need to work. So education would be not only residents, also medical students, and even possibly faculty. Research is kind of obvious. You want to always be doing research to show what you are hopefully going to change or can change. And then advocacy, not at the national level in the sense of advocating for surgery as a profession. That's being done and that's great, but more in the sense of advocating for patients and patients' rights and for underserved and so forth. And then service, because you would hate to be doing all that work but then not actually benefiting your patients. So we try to pull that in as well. And I want to talk a little bit about these pillars to give you an idea of what we're actually doing within these areas. So we made this to just have a nice graphic of what it means to be socially responsible in surgery. So looking at society, community, patient, health outcomes, and so forth. Nice, yes? Very good. Yeah, right? That's a great red up there. Yeah, orange red. So I want to touch base on a couple projects we're doing. We're doing many, many projects, but I just highlighted a couple, not to go into super detail of the actual research, but more to just give you a flavor of the types of things that we think you can do, and then kind of put it under the umbrella of socially responsible surgery. So one is that we do have undocumented immigrants, which you do here, of course, as well. And we looked specifically at end-stage renal disease. So when you look at policy and transplanting, it's based on most of our patients getting emergent dialysis in the undocumented. Few are getting maintenance, and then a handful get transplant. So when you look at who's getting Medicaid patients who receive kidney transplants, this is, and you see California, yay. So here's the issue. So people historically think you should not transplant undocumented immigrants, but when you look at the cost of a transplant versus dialysis and care, of course, we all know that just transplanting will have a break-even point, and the operation will in time pay for itself. And the thought that it's a rare resource, of course, organs are rare, but what people don't realize is that undocumented immigrants give organs to us 4 times higher than they take. So that's a great fact to know. So when people think that we should not be giving precious resources to people who are not documented, well, then we should possibly say, well, then should we still take them from them? Because you can't take them and not give them in a fair world. So then there's ethics, of course, of saying that you should take people who need help and that we should not give it to them. And that should be part of the transplant decision. And then also an argument is, well, what about their outcomes? How do you know you're not going to give them kidneys and then they're going to not follow up? And as we know, compliance is key to having your organs continue to work for years. So we did a study, and this was under SRS, showing that, guess what? They do well. They do fine. They do the same as the other patients that we transplant. So 1 year, 3 year post-transplant, graft survival, looking at all that, they have the same outcomes. So the key for this study is to show that, but then also hopefully advocate and push to show that you can transplant this group of patients, and more states should be doing it. Of course, currently it's Massachusetts and California, which is perfect that we're here, but there's, I believe, 48 other states that then should be doing this as well. So one example of the kind of project you can do as SRS. And fighting, of course, again, for that. Yes. This is Matisse as well, I believe. Yes. So another example comes under education and research, which is great. It kind of fits both. So this was the idea that we came up with, I don't know, 4 or 5 years ago, a while ago, where our patients, especially on trauma and acute care surgery, our patients always need more because they weren't planning on coming to the hospital, so they have an emergency operation or they have a trauma, and then they're there, and they're always kind of have more questions, and they need sort of more from the team. And despite all our best efforts, we're very busy, and you just often don't have enough time to really spend with them. I mean, I've had patients wake up and they see the 4 incisions from a lap chole, and they ask if they thought they had 4 different operations. And so, you know, the literacy of our patients as well in our hospital is at times low. So wouldn't it be great to have more to give our patients? And then you think of, oh, who has time, right? Of course, first-year medical students, right? They're great. Like first-year medical students, we like pick on them, but we should love them. They have time, and they care, and they're interested, and they want to see patients. Well, at least in Boston, I'm assuming it's true here in California, they want to see patients. They would just love it. So why don't we take a group of first-year med students, put them together with our patients who need more, and then it should, in theory, be win-win. So that's what we did. So we brought a group of students in. We didn't just open it up to like the whole first-year class. Well, we did, but then we selected 12. I think first year is maybe 8, then 10, then 12, now 15, because it's like 80 kids apply every year. They're trying to do this. So we pick a select group because we don't want it to get out of control and not work. And then because we also bring these kids in. And then the students learn from us clinical skills in addition to what they're already learning. But we talk a little bit about some surgical disease, such as we go like API, coli, just some basic stuff. We're not going to try and teach them everything. And then how to screen for social determinants. And then just some peri-op stuff too, of like the importance of getting out of bed, the importance of pulmonary toilet, how to use that damn IS, and so they already know as first-year med students how to use incentive spirometry. So the idea that this would be mutually beneficial. So we looked at this. So we surveyed these students. We do the intervention, which is didactics, clinical experience. You roll it all up. It's their whole first year. Second year students lead this under our guidance. I'm a very big believer of you got to make the students lead themselves because I think it works better. And then post surveys. Look how happy they are, right? And look how tired I am. I'm just like, oh, another operation. And they're like thrilled. So you can see the difference. And that is our demonstration kitchen in our cafeteria. We have a food pantry at our hospital, which is amazing, serving over 80,000 families a month. And we have a demonstration kitchen, and she's teaching them some nutrition, our chef. So just not surprisingly, if you work with these students, of course, their confidence in feeling, how do I do clinically and how well am I prepared and how am I going to work with the patients, it's, again, not surprising that it's going to increase. So we just did survey data looking at your confidence working on the wards with the patients, educating the patients and so forth, and this is the increases that we see. And hopefully, too, they're already feeling like they're a valuable member of the team, which they are, because they're doing work that we don't have time to do, and then therefore contributing. And then ideally, they're taking this with them, right? So when they are third-year med students, they're still remembering how to screen for social determinants and how to talk about things like nutrition and so forth. So this was an education project. And again, knowing what social determinants are, how it really affects health, how does it go with surgery, all of that, and increasing confidence for these students who go through the program. So that's an education project. And then finally, we have a lot of victims of violence. When you add assault and penetrating trauma together, like high-level assault, it's our number one mechanism often, higher than falls. So given that we see so many victims of violence, we have a very robust program for that with our injury prevention coordinator, who is, by the way, a member of SRS. So for those of you who do know Lisa Alley, she's a faculty member of our group. So what we had noticed is that our victims of violence seem to not get into rehab at the same rates as other patients. This was anecdotal. We just kind of noticed it, and then we decided, let's study it. And it was very much highlighted when, I'm sure you all know that there was a bomb that went off in Boston several years ago, and those were victims of violence, you would say, but yet 100% of those patients, not surprisingly, got into rehab. So then maybe it's not just the victim of violence part. So we studied it, and we thought that there's going to be differences or disparities based on your race, your ethnicity, your insurance status. And I'm sure you're going to not be surprised to find out that we were correct in our assumptions that it seems that our victims of violence are not getting appropriate dispositions. So we just looked at our center. Again, this would be a perfect example of combining our patients with your patients and seeing if it's the same here, which I have no doubt it probably is. And then we would be a two-center study looking at our patients who are admitted with traumatic injuries and then getting a sense of where are they going and are they going to places that they really are not ideal for them in their recovery. This is home without services. As you can see, 72% of our patients with violent injury go home without services, which is sad, to say the least. And then when you see acute rehabs, and so forth, you see where our patients are going. And some of these patients, of course, can have spinal cord injury. We have patients who have spinal cord injuries, and they're trying to send them home without services. It's awful. And then this is just looking at how less likely someone is to go to acute rehab if you're a victim of violence. So then we did a subgroup analysis, looking at the notes and so forth, and violent injury, realizing that nonviolent injured patients also often don't go to the appropriate place, but less so than the victims of violence. And you can see length of delay and so forth. And then, not surprising, if you send them to the wrong place at disposition, they more often come back to your emergency department. So this was another example of the type of work we're putting under the umbrella of SRS. So whether it's victim of violence, we have nutrition projects, education projects, the undocumented immigrants and renal and kidney transplants. So you can put all kinds of things really under this scheme. So Our other pillar is advocacy. And this is just trying to advocate. In this case, it was related to gun violence, because we have so many patients, unfortunately, who are victims of gun violence. So we're in the med school lobby trying to teach people about, I forget which bill was coming up in the State House, but we were trying to get them to call their senators and so forth and just educate people about the bill that was coming up at that time. All those people there work with our victims of violence, and they do free mental health. We have a program that victims of violence get free mental health through a VOCA grant. And so that's the team who takes care of our victims of violence and does their mental health. And the idea of advocacy, it's kind of sad because so many people think when you look at studies, empathy decreases as you go through your training. I am sure you've all seen that or felt that personally. And then the idea is you're so busy, how can you sort of be advocating because you're busy people? And if you want to take sort of the negative spin, you could say, well, all those early med students, they don't care about these issues. They just somewhat pretend they do because they're trying to get into medical school and into residency. So they're doing these things thinking that they should be doing them, but they don't really care. I would like to not believe that and believe the glass is half full. And I would like to be on the other side where that our trainees, I believe, really do have a true social commitment. It is not fake. I'm not saying there might be some out there, but I think our trainees are the ones who really push us. It's the students coming up and the residents coming up who push the faculty. We teach you surgery, but then you teach us a lot more than you probably think. So does the fault lie actually with us, like as hospitals and as medical schools and our accrediting bodies, like the RRC and the ACGME and all those guys couldn't, they want us to have so many operations by the time you graduate. What about the milestones? Couldn't we put things in related to advocacy and this type of thing? So my hope is that that's the future, is the right side, and the pessimists is more on the left side. So advocacy, when we do it, it does seem we get a huge turnout. Again, a lot of medical students, which is great because they are less busy. I mean, of course, you guys work 80 hours, you don't have time, you're working, but this was a Mother's Day walk for peace. This was the gun violence walk and so forth. So we get together, walk. It always seems to be raining in a lot of our walks. But it doesn't rain here, correct? Correct. So you guys could do this all the time in beautiful weather. So even more reason to be out there walking because you have beautiful weather. So kind of to sum up what we have noticed now that we're in our 5th year of SRS, this is getting ready to walk. We are making our posters in a hotel room to meet there. But it's really opened us up to other departments. Like the pediatricians before used to just tolerate us. Now they love us. It's great. The chair of pediatrics, he's like one of my biggest fans because he's just so excited that there's a surgeon who cares about this, which is so sad. But so we are working with primary care and OB-GYN. We're doing a project with OB-GYN and lead in women of childbearing age because if you have a bullet inside you that previously we thought it didn't matter, now there's new data showing it might matter, especially for women, and they could have miscarriages because of lead poisoning. So we're working with OB-GYN. It's just really great in that sense. Institutional recognition, we now, again, after some years of doing this, but the whole institution knows who we are, what we're doing. It has legitimacy, so much so that people talk about it like it's a real thing. And you have to somewhat chuckle and go, oh my God, I just invented this. But we don't say that anymore. We just say thank you, and we move on. And then trying to, of course, build and get grants and money. We're getting money as well from our development office. So our hospital, sadly, we have grateful patients in the terms of like they're grateful, but they don't have money to give. So we do not get money from our patients, not surprising. So we need development offices, and then we get rich people to come and tour our hospital, and then we sell them on the amazing work we're doing, and then ask them to write checks for $10 million and so forth. And they do, and it's great. And then we are getting part of that money as SRS because they are coming and touring our hospital. We have increased community contact. We want to work with community groups who are in the same arenas because we don't want to be so naive to think that like we as physicians can solve these problems. We need to be involved with the communities. When you look at our trainee interest, it is skyrocketed. Now our residents who are coming into our class, it's almost as if like if you don't care about this, the chance of matching into our program is less because it's so much of who we are. It just doesn't make sense. There are so many residencies across the country. If you don't like to take care of poor patients, there's many residencies for you, but like ours is probably not that one. So we can now focus our training, and so everyone who comes there like really does care about this. Not that to the point that they have to be doing research and so forth, but just overall caring. And then we have found that medical students more often are going into surgery over the past several years. So when I first arrived there, but that was like a decade ago, like 6 people were going into surgery. This current year, we have about 28 students interested in surgery. So all of this work, not that this alone is it by any means, we have other projects and things we do with med students, but just paying attention to them and getting them involved in surgery early and giving them ways to get involved, I think really helps us as a field attract medical students, which we do need. So I'm hoping that with my talk and this, that we can show you that you can really just kind of pull these ideas into your daily practice. So I like this quote a lot because I feel that this kind of sums up everything we're trying to do. And this is us, and we do have a website, and we do have a Twitter account, of course, and that's us. And then look who this is. Oh, this is you. Isn't this great? This is you. You already have a logo. So, right? So it's legit. Like it's done. You're already legit. You have a logo, and you have a Twitter site as well. And do you notice the difference? You see? Look at ours. No bridge. Look at yours. Bridge. Kara, I believe that was you. I mean, you didn't build the bridge. I know. Yes, the bridge. So yes, happy to end there. And I think there's a slide that you have for your upcoming meeting.
We're gonna have like a brainstorming meeting next week for residents and any faculty who are interested. You guys will get an email about it sometime this week. So, and you can follow us on Twitter if you're not ready to do that yet.
Yes, we should have a competition. We're at almost 400 followers. I think you're at like 40. So we could like have a friendly competition, and whoever gets to, 1,000 first wins a prize or something.
I can make that happen.
Thank you.
So this is really a great fun story. I was a visiting professor at Boston University, probably about, I think you were in your second year, maybe, when I was out there. It wasn't that long ago. And I remember thinking, oh my gosh, this is UC Davis. That this is so similar to things that we care about, that are core to what we do. We've had such similar patient populations. And so this conversation got started about how could we, would it be okay if we became a chapter? And they're like, a chapter what? And, we continued to have conversations, and I started talking to residents here who said, yeah, this makes sense for us. And so faculty, all kinds of people who have wanted to sort of jump on your bandwagon and expand the vision that you guys have developed. And it's a perfect fit for so much of what we do here. So we really thank you for your amazing leadership in this arena and making it easy for us, sort of giving us a roadmap for how to sort of engage different audiences, if you will, your hospital as well as other advocacies. So I just am really so impressed with the work that you guys have done at BU, and thank you for your great leadership in this. So I really want to give a shout out to Kara and her gang who really helped make this happen here. And we are going to have some time to spend, a little bit of time to spend with you and your colleague, Dr. Janeway, who also has really been so important in making this happen. And, really great to be bringing the resident with you on a visiting professor gig. So I love that. That's really, it gave me more ideas as well. So
great.
Lots of leadership. So we have some minutes, we have a moment for some questions. I think this is really an important piece. Dr. Brown.
Outstanding talk. I was just curious. This kind of work involves a very critical look sometimes inside, like in the mirror. And I was wondering what the energy from the administration of your institution was like in year 1 versus year 5. If it changed, how did you make it change?
Oh, yeah. So, great question. You're correct. In year 1, we were just like a group of people hanging out together in my house. I don't know, do you all like wine here? So we would get together and drink wine and have some pizza. It was very low key, but we just were really passionate. The group of people was maybe 5 or 7 or 8 just of us were really passionate about it. So we just kept going. And I think now we went through those trials without even necessarily realizing, in a sense of we just kept going. And I know there were people who were like, oh, whatever, or doubting or thinking it wasn't legit. And now it's to the point that the development office is like raising money for us. Like it has come quite a ways, and we just kept going. Like we didn't really listen to detractors, or we just kept going. And I think that's the beauty of people who care about these types of things. Like they care no matter what. They're not going to stop. So you just got to find the people who really care. And often it is medical students, actually. And I know medical students, like, are there any medical students here?
Yeah,
No, you
actually,
see,
yeah,
yes, you see, right? Like,
Names specifically, I think.
so just kept going, just kept plugging. And I think having the framework, we have a mission statement, we have a website, we now have research, we're trying to publish, like just showing like this is legitimate, we're doing great work and getting it out there. We're now in the surgery annual report. We get written about every time. It's really just become legit over us continuing to push, and yeah.
And I think that, that's what struck me in the beginning was you are all doing so much of this work to begin with, but having a framework, having a structure, having a way to codify it, I think adds this air of legitimacy and help, and it really, and I got to admit, I really do love the logo. So we're proud to be your first chapter.
Yes, very exciting.
Other questions? Dr. Goodnight.
Dr. Decker, very fine talk, even more importantly, the work you're doing and so forth. Margaret Mead's very fine comment, notwithstanding, making social change is incredibly difficult. As you begin to gain traction now with what you're doing, which is wonderful, as you lay awake at night, what is your highest priority in the next 5 years?
Great question. I think, and I do lay awake at night a lot, because the world is really doing just fine, though. I don't know why I would not be able to sleep at night. There's no issues really going on, but I still, yeah. So I think our ultimate goal is to get this established as a national organization with chapters throughout the country, so that surgery and social goes right together, and it's the days of thinking that it's the pediatricians are over. So I think that's our ultimate goal, is to have it nationally, so students and residents coming up are aware of it, and it's like, I like this type of thing and there's a place for me, and that's our goal.
If I may make a quick follow-up then, do you want to make an effort to connect with government, or do you want to run parallel or even different?
Well, I guess it depends on who the government is. I would say now we'll run parallel.
I think that there's no question that surgery is, we're at the tip of that spear, because the patients come through the emergency room. That is really, and we are often, there's not a day that goes by that I don't get a complaint from somebody about, why is this patient on our service? And the answer is, this patient is on our service because there is no place else to go. And we just say yes. And there's a lot of tension around that. There's a lot of patients that have all these problems that people say we surgeons can't take care of, yet we continue to do this. But
Right, good point.
We're the tip of the spear in so many ways for so many patients. Dr. Rack,
So over the past 20 years, I have a myopic view of the world. This is my job, but we've become more dependent on technology and minimally invasive approaches to surgery at the expense of open surgeon, nowadays, you don't see or do that much of it.
Mm-hmm. Yeah, that's a great point. I think we've grown quite a bit when we think about the global part of it. And I think now working with the local government there and the country there and what their needs are and having them more run and direct it with assistance from people maybe in other countries, but not us driving it. So I think we have somewhat become more humble and realize we can't just take what we do and take it places. We go to those places to see if we can help them do whatever. But I think that's the key, to then not have it where we're taking our standards and putting them on other places. So you have to get the local involvement, which gets back to your comment of like governments are often, there's bribes and there's greed and there's power and then there's all those dynamics and you're trying to fight that to get money for poor people. So by no means easy, and this I have no doubt I will live my whole life and we won't have solved these problems. But we got to at least, I guess, keep working on them.
I think that's a great point to one of the reasons we combined our global and our rural health track, because we think some of the challenges and skill sets, to your question, that you need are very
Right.
similar.
Right.
So we work that way.
Right.
Dr. Brown.
Great talk. Very excellent work that you're doing. The question is, how do you train the people in your program or your surgeons and your medical students about cultural competency and things, because the patient comes into the hospital and that's kind of that's your home, right? And you can take care of them so well, but then we don't really know what goes on once we discharge them, unless these types of programs can be great for feeding the community. What types of community efforts do you make to understand, where these patients are coming from and what their belief systems are, because that can have a huge effect on medication compliance,
Right, sure.
healthcare utilization, a whole host of things.
We are very lucky to have a lot of connections with community groups from our hospital. So not just through this group, but for example, we have a refugee and immigrant health center. So that whole group does that, but then we can work with them and take from them and they, work together. And then we are very active, like I said, in the victims of violence and mental health. So that's out in the community. So we have a lot of work with community groups based on violence. So we do have more to do, but I think it's using the connections we already have through other departments at the hospital, because there are a lot of people doing work like this. It's just like we unfortunately work in silos. So the OB-GYN and the peds and family medicine, we don't all know what each other is doing. And a lot of us are doing really great work and we just aren't talking to each other. So I think that has been key, is breaking down the silos to then know and then work together on similar type projects or use each other's connections and so forth.
Well, thank you again for this great work, and I know you guys have a short time before you have to take off for your East Coast travels, etc. But we will have a little time for residents and
Great.
trainees and medical students who have time to spend some time with you. So thank you again, and thank you both for coming.
Yeah.